Here, since I'm at home, I have the luxury of looking things up. Malaria levantinese, it comes from the malady of the Levantine Valley. In the early 1900s, they found this family, and this is why it's autosomal dominant. There's this family in the Levantine Valley of southern Switzerland where they had this macular dystrophy pop up. And a few decades before is when Doyne had recognized it in another population. So malaria
nice. I had the two names.
a malady of this family that they found in a particular area of Switzerland. So that's where that term comes from. Or more easily, just familial drusen. Much easier.
Okay, can you guys see my screen?
Yes.
Okay. So this is a 42-year-old man. 6 months ago, he woke up with a blurred spot centrally in the left eye. He then went to the ER and they ruled out a retinal detachment and his stroke workup was negative. He was not found to have anything specific. He is a nurse anesthetist. The patient was told to get a further evaluation. There is still a spot in his left eye, but he can see around it. The spot has improved since November. At night, the vision is a blur and there are a lot of halos. The spot is a smudge that he's looking through. He can move the spot briefly, but then it recenters. He doesn't really have any like pertinent medical history. He doesn't take any systemic medications. Vision in the right eye is 20/20, and in the left eye it's 20/16. IOP was within normal limits.
This photo, right eye. Nerve. Here's normal. The edges look a little crazy, but I think it's artifact. I think it's a normal nerve. There are these hypopigmented lesions temporal to the macula. They're pretty large.
Well, you know, it's having trouble hearing. I think that's what it's saying. Move this more toward the middle. All right.
Some large hypopigmented lesions temporal to the macula. There's some smaller ones just inferior to the fovea a little bit, it looks like as well.
Okay.
On this photo, left eye, similar kind of larger, what looks like hypopigmented lesions. Inferotemporal, retina and kind of superotemporal as well. Maybe some smaller ones, just superior to the macula as well.
Okay.
Zoomed out fundus photo of the right eye. Similar findings, large hypopigmented lesions, temporal, temporal retina, mid-periphery. Maybe a little bit inferior as well.
Mhm.
And they are a little bit in the macula as well. Similar findings in the left eye, large hypopigmented lesions, temporal and inferior retina, mid-periphery, maybe a lighter one, superior nasal, and some hypopigmentation in the macula, it looks like, a little smaller size lesion.
Okay. So I don't know why it's off to the side, but
OCT scan, the retinal architecture seems preserved. Maybe like maybe a little disruption on the left edge of the screen and the outer retina maybe, but I think overall it looks pretty normal.
this is the right eye. It's just straight through those lesions.
Those regions appear to have very thin retina. It appears a little atrophic.
So the part with the lesion, I believe, is on the right side of the screen. So it scans from the arrow, I think it's on the right side of the screen.
Yep, it is. It's on the right side. Here.
increase, maybe things that would be thicker compared to the other side of the screen, than compared to the left side of the screen, then so retinal thickening.
Okay. Good.
There's, I'm sure if that's like an artifact, but just next to the fovea, there's kind of unclear retina, but there's a little, maybe a little. Overall, it appears relatively normal, except for maybe like a decreased signal to the left of that fovea, but I think that might be an artifact. That's more artifact, I think.
Yeah, that's nice. Pretty normal.
That fluid appears a little thick, I think. Maybe. Overall preserved retinal architecture, it looks like.
It's hard because you're not used to looking at scans in the periphery. I mean, we do get the peripheral macular scans, but you don't like scan the periphery.
Great case. You got him stumped. I love it.
It's a funny looking around.
So that was pretty good, but there was like a hyper reflectivity over here in the peripheral macula when you scan through those lesions, and then that other peripheral scan was also had that hyper reflectivity in the nerve fiber layer right there. There's another one. You can see that hyper reflectivity right over here.
Right.
Is a normal peripheral retinal scan would be what you see in the middle of this picture.
Okay.
So, and these are the abnormal spots where it's kind of right. You know, that's more
Picturing hyperreflective.
kind of like when you get your line scan through the macula, the part that's away from the nerve looks like that. You don't see much. Or if you have a real bad glaucoma patient, you know, the inner retina is not super exciting.
Here's another one kind of showing that same hyperreflectivity. So just a quick summary of the findings. From the fundus photos in both eyes, there were some yellow-white striations along the temporal macula and arcades, and it kind of had a feathered border. The OCT of the macula showed a normal foveal contour, and it had a partial PVD without a BMT. And then the OCT of the peripheral retina in both eyes had some hyperreflective material and thickening in the nerve fiber layer. That
So
was
go
other
back to colors, just what to think about. Is that okay? Can you scroll back to the,
colors.
yeah, one of the wide angle colors? Yeah, just like that one. All right, so what's your differential for that picture?
It would be like a syphilis, like a posterior placoid. Syphilis, maybe other infectious causes like posterior uveitis, vocal choroiditis.
So you're gonna go to white spots, like big white spots.
Mhm.
Yeah, that's good. What else can cause retinal whitening? What infections do you think of for retinitis?
Just going through all the basic ones like toxos, syphilis, TB,
The viral
CVD,
retinitis.
but I would
Yeah,
expect more like hemorrhage, maybe, HSV, VZV.
good. So you got your infections, inflammatory, plastic, and then there can be congenital lesions. These are, if I told you these were probably congenital.
Oh, like CMV maybe, congenital CMV, possibly, or.
This is 42-year-old guy.
Yeah, it's a tough one because it's a weird, these are funny looking.
You'll never get this wrong again.
It's not a typical presentation, but go ahead. You want to do your differential there?
Sure. So it was kind of hard for me to find a differential, but I was kind of working off of that it looked like cotton wool spots initially to me. Like that was my first thought when it came to retinal whitening. So cotton wool spots, and then all of the causes of cotton wool spots. So vein occlusions, artery occlusions. If you see this in a kid and it's a large area, it could be confused for retinoblastoma because it can cause leukocoria. You can see metastases, chorioretinitis. You can have a coloboma of the retina, and then also myelinated nerve fiber layer. And then I put metastases on there twice by accident. But
Nice.
so it is a myelinated nerve fiber layer. So retinal nerve fibers that are myelinated, they are retinal nerve fibers that are myelinated, and they're usually anterior to the lamina curvosa. Usually myelin starts posterior to the lamina curvosa. It's caused by a developmental error involving the presence of ectopic oligodendrocyte-like cells in the retina, leading to the myelination of the nerve fiber layer. Clinically, they appear as gray-white patches on the anterior surface of the retina. They're usually adjacent to the optic disc, but they can really occur anywhere in the retina, kind of like we saw. So it wasn't really adjacent to the optic disc. It's present.
Almost adjacent. That's why this was so confusing. You almost always see these things off the optic disc, but sometimes you get these funky ones, which I think are beautiful to look at off to the side, but that's why it was.
It was a very unusual case.
It's a very
There's
unusual.
several of them.
Yeah, and it was.
I've never seen, I don't think I've ever seen it.
Yeah, well, we don't have that the camera, we didn't, the cameras are so nice for that now. Sorry, I don't want to interrupt. Go ahead, Sarah.
Oh, you're
No,
good.
that's Sarah. Yes, Sarah, you are Sarah.
So it's usually present, it can be present in roughly 1% of the population, but of that 1%, 7% of those patients are affected bilaterally, kind of like our patient. It's typically present at birth, but a few cases have been reported of an acquired myelinated nerve fiber lesion, but then it can also be progressive, and then sometimes they can also regress depending on things that happen to the eyes throughout life. So these are some associated conditions. Usually it's isolated, but patients can also be myopic. They can have some amblyopia because there can be like a central scotoma if it's quite large. And you can also have strabismus, keratoconus, Turner syndrome. There have been cases with epilepsy, Down syndrome, and then also craniosynostosis. So you can have some cases that are acquired or progressive. Usually it's congenital and it's static, but there have been some case reports that show that there's been some progression of the myelination in childhood, adolescence, and adulthood, so kind of just throughout life. It's usually associated with blunt trauma, optic nerve sheath fenestration. That's kind of when it's going to progress. You can see optic nerve drusen, and then a family history of optic nerve hypoplasia. You can see it with Arnold-Chiari malformation, neurofibromatosis type 1, and then Leber's hereditary optic neuropathy. Also, like I was saying before, you can also have loss of myelination. It can be seen when there's a lot of ocular inflammation and retinal disease. So when you have kind of damage to the retina, you kind of lose that blood flow, and then they can regress a little bit. It can be seen with pituitary adenomas, optic neuritis, glaucoma, plaque radiotherapy. You can see it with BRAOs and CRAOs, diabetic retinopathy, and then after a vitrectomy for an ERM. So you can actually lose some of the myelination. For its management, it's usually benign, but you just have to rule out other conditions. So it can look like a cotton wool spot, like we were saying before, but that, has its own workup. But you want to do a fluorescein angiography just to make sure that it's not a vascular occlusion if you're not sure. You can do visual field testing to rule out a relative scotoma, which can be a cause of strabismus or amblyopia in kids. Serial eye exams to check for progression or regression. And then just make sure that it's not retinoblastoma if it's a cause of leukocoria in children. So something important to rule out. And that's kind of it. So not much to say, but it was an interesting case.
Go back to the colors. So if you notice, you could actually see the nerve fiber layers, the one directly inferior. And they're in the distribution of, you can see the striations of the nerve fiber.
Yeah, so they're feathered, they're following.
Yeah, and they feather out, yeah. But that one in particular, you can
This one
almost see
up
the
here.
striations.
Yeah, they're kind of pretty. And then it's almost always on the nerve. This is a weird case that they're out here like this, but but you do see that sometimes. I have to say, I have seen just these solitary patches. Sometimes I'll see a big one like here, a wedge,
Yeah.
But it's just good to know. And it's one of the many things you need to know to succeed in your career as ophthalmologists. I think that's all for cases. Matt had one and he's not here. And then I think we did 5, which is pretty good. We finished just a switch row. Does somebody else have a case? Does somebody? No, okay. All right. So,
Dr. Cohen,
yes.
yeah, this is Don Noel from Abidai Group.
Oh.
Yes, how are you today?
Oh, nice to see you. Hi.
Good. I was trying to speak during the previous case, but I was muted. Yeah.
Oh.
So, yeah, because pattern dystrophy can be easily mistaken for macular degeneration. I would lean toward more a pattern dystrophy for this case than macular degeneration. First, the patient is 54-year-old. Second, the symmetrical appearance of the lesions plus a butterfly shape of the left thigh. So I would do a genetic testing just to check for PRPH2 before I make a diagnosis for of dry macular degeneration.
All right, thank you.
Yeah, so that's my opinion. You know, I mean, yeah.
What else we didn't discuss is we didn't discuss treatment of birdshot that much. And I probably have 20 or 30 birdshot patients.
Oh, birdshot.
Yeah, we didn't talk about treatment that much because most people recommend systemic treatment. I tend to treat more locally, but most people recommend systemic.